before we start, I definitely want to say thank you to all of our amazing partners helping us to put this all together. Let's make some noise for the GRMC Cardiology Department, please. Let's make some noise for TMC Referral Office. Thank you so much, Kuya. We want to make some noise for the Micronesia Mall. Thank you so much for having us. MD Wholesale, because we love everything about them. Thank you. And let's make some noise for Philippine Airlines as well, ladies and gentlemen. All of them coming together to make events like this possible for our community. Now, you know at Guam Regional Medical City, patients are our partners, and that's why it's so important for us to come out into the community like this. This is not our first, this will not be our last. There's going to be a lot of great outreach activities like this going on. And anytime you see these banners, you come and join us, okay? And tell your friends to do the same thing. Today we're talking about something very important for our island. We're talking about your heart. Now, a lot of people here have huge hearts for giving and for loving and for sharing. That's wonderful. But sometimes having a big heart's not a good thing, okay? So a little too big. We're going to learn more about that right now as I welcome to the stage somebody who is well-versed in the proper sizes of hearts. Ladies and gentlemen, please welcome Interventional Cardiologist, Dr. Mahesh Golla.
Hello everyone, good morning. This is Dr. Golla, one of the interventional cardiologists at GRMC. And thanks for coming and joining here today with us and learn about a few common diseases and how we treat at GRMC and how we prevent cardiovascular diseases in the island and to promote heart health to make and to keep your heart strong. All right, let's get into that. So, I just want to start very common interactive way, and most commonly we get some questions every time we go and reach to communities, community outreach programs. There are some common questions people ask. So I want to explain heart health in terms of those questions. So the common questions are how common, obviously, the heart disease in Guam. So what are the common problems associated with the heart? And my heart function is normal or low. What does it mean for me? And what does it mean when the heart arteries are clogged to you? How do heart arteries blockages begin? Am I at risk for a heart artery blockage? What would I feel if I have a heart artery blockage? Do heart blockages start at the time of chest pains? How can I prevent heart attacks? Very common questions we get. And what does a cardiologist like us, or Dr. ElBebawy, or Dr. Polisinski, and Dr. Inaba, there are 4 or 5 cardiologists on the island, do in the cath lab if we encounter any heart attack patients? And what medications should I take if I have a heart stents or a heart attacks? Do I need a screening or a testing for heart blockages? Patients usually have these questions before the heart attacks. So, first question is how common heart disease in Guam? There are yearly almost 10 million people develop chest pains in the United States, and heart disease being the #1 cause of death in the United States of America, and also across the world, not just US. And the Guam is not exceptional. As you can see, the first, one second. As you can see here, the ischemic heart disease, which is a cardiovascular disease, is the #1 cause of mortality in Guam. Compared to 2011 to 2021, the significant increase in mortality, that means people died with the heart attacks in Guam. Could be various risk factors, but the trend is going up. So how about not just mortality combined with morbidity? That means people who cannot work or cannot deal with the day-to-day activities after heart attack. That is also going up, as you see, 20% hike from ischemic heart disease in 2021. So coming to the second question, what are the common problems associated with the heart? Anytime any patient comes to us in the clinic or in hospital in emergency room for various complaints like a chest pain, shortness of breath, dizziness, palpitations, leg swellings, whatsoever, after getting a history, we usually come to 5 common grounds to diagnose your heart condition and followed by treatment. Those 5 are: what is the heart pump doing? We measure in terms of ejection fraction. If your heart pump is weak, that means you have a heart failure. That's what the diagnosis we generally make. There are many types in heart failure. That's out of the discussion today, but commonly we consider them as a heart failure. If the blood supply to the heart, as you know, heart is almost size of your fist, sits on your left side of the chest. It gets blood and pushes blood, right? If it is acts like a pump, it needs a gas to move. So just like a plumbing. So that plumbing system, if it shuts down or a blockage is developed, we diagnose them with a heart attack or a coronary artery disease. Next thing is, if anyone asks you, oh, what is your heart rate? You say, hey, 70 to 80 beats per minute. That means God has given a kind of chip inside your heart which lets you beat your heart in 70 to 80 beats per minute. Sometimes it gets slowed down, sometimes it gets faster. So we usually call them as an arrhythmia if it gives you any trouble. Usually people feel dizziness and palpitations. So, and also the blood flow within the heart has to go in one direction. It shouldn't come back. Just like our routine plumbing system in the house, to direct water to one direction, we have a valve, right? God has created 4 valves inside the heart to direct blood in one direction. So if any problems with these valves, the 4 valves, like a mitral, aortic, tricuspid, and pulmonic valves, either tight or a leaky valve could give symptoms. So the last thing is heart beats close to 100 to 125,000 times in a day. So it pumps continuously while we talk. Everyone's heart's beating, right? So it generates heat that has to be dissipated. So it sits in a pouch we call pericardium. It creates a water around the heart which dissipates the heat. So there are some problems could occur, maybe viral infections, some kind of cancers, whatever it is, usually gives a problem to the pericardium, could cause some symptoms. So then we talk about heart pouch. These are common 5 conditions we usually diagnose out of all the heart symptoms people do have. This is common general human heart anatomy. The things what I want you to remember moving forward, as I said, first thing, heart pump, right? You see this muscle? This pump usually dilate, gets blood, and pushes blood outside. It pushes the blood into this artery, so the rest of the body will get blood supply. And once blood reaches the tissues, the oxygen will be used by the tissues. That bad oxygen, that means blue blood, comes back here with this blue direction, comes here, and goes into this blue side and goes to the lungs and gets oxygen, and again the circle starts. So things you need to remember, this is the right side top chamber, right atrium. This is right side bottom chamber. This is left side bottom chamber, left top chamber. Total 4 chambers within the heart and 4 valves. This is a one valve, the white one here. This is another valve called aortic. This is mitral. Something inside is pulmonic. And this is inside the heart. If you look at outside these tubes, this is the plumbing system of the heart. There are 3 main arteries, tubes, supply blood to the heart. There's a few common things to touch upon to know what kind of common heart problems we see. So other common question is, my heart function is normal or low. What does it mean? So as you can see the CT picture, this is right top chamber, this is left top chamber. This is right lower chamber, left lower chamber. You can see this is the main chamber because it pushes blood. As you can see, the white is blood. And this is muscle. Every time it dilates, contracts, every heartbeat, it pushes the blood. So which we measure in terms of this number, ejection fraction, more than 50 to 55%. If the number is normal, that means your heart is efficiently pushing blood to the rest of the body. And coming to another modality, what we use, previous picture I showed is CT scan, CAT scan, and this picture what is showing is echocardiogram, ultrasound of your heart, patient's heart. We commonly do these testings in clinics. As you can see, this is the main heart chamber. This is left top, this is left bottom. Again, expanding, pushing blood. This is grayscale on the left side, but if you look at the right side of the screen, which is color flow, which is the blood, basically the blood, if I put some artificial intelligence and some kind of technology in there based on ultrasound waves, you can see the blood is coming this side, going this side. But you can see some jet is going back. That means this valve is leaking. So, but I want to see rather two-dimensional view. Nowadays in GRMC, we have a more sophisticated technology to see the valves in three-dimensional views. The next picture is showing you this valve. If I put a camera here, I'm looking at this valve, how it looks like. This is the way it looks like. If I'm putting the camera here, I'm looking at the valve in three-dimensional way. This is the mitral valve looks like. This is the aortic valve looks like in three-dimensional view. So how does a weak heart looks like? If patient has some kind of viral infection or a heart blockages causing heart damage, sometimes it is irreversible. The heart function won't recover. As you see, this heart function compared to previous two slides, heart is only doing this. It is not doing this. So here, ejection fraction is only 15% approximately. So this particular patient's heart is weak, so the blood won't go to the rest of the body, and they do have a lot of clinical presentations. So the other question, next question is, what does it mean when the heart arteries are closed? So as I told you, there are three main arteries, tubes, gives blood supply to the heart. Those are LAD. We usually call them as a widow maker. And this is called left circumflex. We call them as a left artery. Another one is right coronary. We call them as a right artery. These two combined called left main artery. All right. Now imagine you're a surgeon. You're approaching a heart. How from the skin, if you're going inside, how the heart looks like. I'm going to show it to you. As you can see, this is the skin. I'm taking the skin out. You can see the rib cage. Now I'm took the rib cage out. You see the heart. This is aorta. This is left bottom chamber. And these are the tubes, the right tube. And now we are coming back onto the skin. This is how the heart is located inside the chest in mediastinum. Now you came to the heart itself, and it is a pouch, I told you, heart locates in. Now you are just taking the pouch out. Once you take the pouch out, you see the right bottom. I'm taking the right bottom chamber out. You can see the left bottom. This is the right artery. This is the widowmaker artery. This is the left side artery. And again, I'm putting the right side bottom chamber back in and coming back to the heart pouch. This is the way the heart anatomy looks like. So, coming to the learning more about the plumbing system of the heart, I told you there are three tubes gives blood supply to the heart. This is called right artery. This is called widowmaker artery. And I'm going to turn the video on so you can see the left artery is here. So these three tubes gives blood supply to the left bottom chamber and left top chamber. Imagine it's just like a regular water system to our household. This aorta, this water tank is going to be the aorta here. Blood comes from here through these tubes to the muscle. So muscle get oxygen and the nutrients and it will survive. Imagine if I shut down the flow here, the whole heart muscle here will die. Just like if you shut down the water tank here, the community won't get a water supply. The same way, right? So that means all heart attacks are not deadly. If you have a heart attack, the artery blocked here, that means major heart muscle will die, that could be lethal. But if you have a small blood vessel here blocked, only part of this one is blocked, only part of the heart muscle dies is only small area. Usually, people present with the chest pains and they are not usually lethal. So that's why it's a spectrum rather a binary. Heart attack, people die, is not like that. The various spectrum of heart attacks we see all the time. So if you imagine this in a real time, as you can see, the plumbing system and the tubes supplying the heart muscles. And this is another view of a three-dimensional heart. These are like a right bottom chamber, right top chamber, left top chamber, left bottom chamber. Now you can see this is right artery. This is called widowmaker. This is called left artery. And these two join and cause this small segment is left main artery. So I'm rotating and also taking the heart muscle out of it so that you can see the only plumbing system or at heart tubes supplying blood to the heart muscle. This is the basic anatomy you need to know before you understand what we do. So this is a CT angiogram, cardiac CT angiograms we do at GRMC. This is one of my patients who came in with the chest pains and young age with risk factors. We do CT angiogram. Basically, the way we do that is we put an IV in, we inject a contrast. The contrast goes to the heart, or a dye goes to the heart. We take a CT scan pictures. We render them in three-dimensional technology, and you can see the heart arteries like this. I'm rotating the tubes. This is right. This is widowmaker. This is left artery. I'm rotating in three-dimensional view and see how beautiful these arteries looks like. But this arteries does not have any blockages. Now widowmaker does not have any blockage. And now the left side artery, no blockage. Not even a 0% blockage. It's completely clean arteries. Very useful test. This is sometimes better than the angiogram we do. The angiogram is an invasive procedure. This test gives you more information if it is done properly. And how does this blockages looks like? Once they have a heart blockages developed in the heart arteries, the same kind of arteries I showed it to you. You can see these white dots here. You see these white blocks. That's how the blockages look like in CAT scan. And here, there's a blockage here, there's a blockage here. Based on the severity, we grade them either 50%, 90%, 80%, depends upon severity. All right, next, go to the next question. Now we know the heart anatomy and the chambers within the heart and also the tubes supplying blood to the heart. And you saw that, plumbing system of the heart with the three tubes. Now, how do heart blockages begin? Common question, why do we have a heart blockage, kind of thing. So this slide on the left side will show you the cross-section of a tube, a blood vessel, at various phases. The one thing I want you to remember is initially, the first decade of life, that means less than 10 years of age, your tubes are looking like that. But once you're crossing to 10 to 30 years of age, you see these blockages develop. Don't think these blockages only develop at the age of 60. At the age of 60s and 70s, people present with the symptoms, but blockage is going to be already started while you are teenager, 10 years, 20 years of old. So the fatty streaks, that means the fat deposits, cholesterol, the bad cholesterol deposits around 10 to 20 years of age. People who follows, again, bad diet, smoke, diabetes, high blood pressure, cholesterol, family history, the blockages grow and grow and grow to the point it almost blocks the blood flow here. So if anyone wants to prevent heart attack, the prevention should start early. That means teenage, not at the 40s and 50s. But the other spectrum of it is, imagine it grows up like a volcano, and suddenly one unfortunate day, it ruptures. As you can see here, the tip, like a volcano. Once it ruptures, it creates a blood clot, and it completely shuts down the blood flow. That's when the people suddenly, without any issues, develop chest pains, and they rush to the hospital with a major heart attacks. And that's when we emergently take them to the cath lab, and we put a stents to open those blockages to save lives, because people die if the artery is blocked suddenly. So this is one of the schematic diagrams showing you the blockages develop over time, and suddenly you can see here, it ruptured and creates a blood clot, and it blocks the flow. So am I at risk of heart blockage? Yes, if you do have a history of high blood pressure, high cholesterol, smoking, diabetes, obesity, physical inactivity, like a couch potatoes, and unhealthy diets, and age more than 45 for men and 55 for women. Family history, that means anybody in your family, mother side, father side, developed a heart attack or a stroke or a blockages in the legs, you are also at high risk of having a heart blockages. And a stress, type A personalities, they do develop heart attacks. And alcohol, excessive consumption causes blood cholesterol and blood pressure variations, could trigger heart attacks. Taking 1 glass of wine a night is really helpful, but I'm talking about excessive alcohol intake, which is considered like a more than 2 glasses for a man and more than 1 glass per woman. All right, what do I feel if I have a heart blockage? So if you do have a heart blockage, most commonly, they feel chest inconvenience or a chest pain, chest pressure, and burning pain, whatever the type of pain. They do have some kind of inconvenience in the chest, starting from the jaw, lower jaw, onto the belly button. Anything in between, we suspect a heart-related blockage. Or shortness of breath, or dizziness, fatigue, passing out spell, syncope, palpitations, and lower extremity swelling, all could be signs and symptoms of a heart blockage. The other question we get is, hey doc, my heart blockage starts when I begin experiencing chest pains. Answer is no. It starts way before you start developing chest pains. As you can see, by the time you develop chest pain, your blockage already more than 70%. So that's the reason we do the stress tests, EKGs, echocardiograms, to find the blockages while they are smaller, like a 30, 40, 50% blockages. By the time you have a chest pain, blockages are already out of control. You may need some stents or something else. So the next question is, how can I prevent heart attacks? Once you know the risk factors, you need to control those risk factors. If you have a high blood pressure, your goal blood pressure is less than 130/80. If you have a high cholesterol, especially LDL or LP(a), you need to make sure you control them at the target levels, usually less than 70 if you have a heart attack. And if you're a smoker, please stop smoking. So if you need help, at GRMC we have a lifeline. We can help with quitting smoking. You may need some medications or nicotine patches. And the diet and the weight. Diet-wise, Mediterranean diet, which usually consists of vegetables, fruits, nuts, olive oil-based foods, skinless chicken, fish. That's what we recommend. Anything pasta, sweets, sugars, red meat, any refined products usually affect negatively on your heart health. And the sodium also we recommend less than 2 grams, mostly less than 5 grams, nothing more than that. And the weight, we usually recommend BMI in around 18 to 25 range. That's what we usually recommend. So diabetes, as you know, HbA1c, hemoglobin A1c, just control it according to your age. So, but if you are diagnosed with a heart blockages and diabetes, there's a new medications in the market called empagliflozin or dapagliflozin, Farxiga, or a Jardiance. They are like a miracle medications, like a statin. Try to be on those medications. And exercise-wise, we recommend at least 30 minutes of aerobic exercise a day, at least 5 days a week. Or if you want to do high-intense exercise, more than 75 minutes a week is sufficient. And if your risk is higher for a heart attack, we also recommend aspirin. But we do not, or we stopped recommending aspirin routinely. We don't recommend routine aspirin intake. We used to until 5 years ago. 2019 or 2018 onwards, we stopped recommending aspirin routinely. We only recommend now if you are higher risk for a heart attacks. So what are the treatment options for heart artery blockages? Obviously, as you know, we can do non-interventional, like medications, risk factors adjustments, and cardiac rehabs and exercises. And interventional, doing something procedurally. Either we can put a stents, and we can do also bypass graft surgeries. Unfortunately, we do not have a CT surgeon in Guam. If anyone needs a bypass surgery, they have to go off island, either to Hawaii or Philippines or mainland. So what do I do as a plumber, as an interventional cardiologist in cath lab if we have a heart attack patients? Let's go with one of the heart attack patients we treated recently at GRMC. Before I go in, I just want to give a big shout out to my cath lab team. They're like heroes. They just, come 24/7 anytime. They also help with the strokes. They also help with the heart attack patients. They come within 15 to 20 minutes to keep the ball rolling. We do the procedures, but they do the groundwork. So, yeah, I just want to definitely, I would consider them heroes in cath lab. So coming to the cath lab, how it looks like, these are the cameras, this is the X-ray camera, these are the screens, this is the table where the patient lie down during the procedure. So what we do is, we used to do before going through the groin and pass catheters all the way to the heart and inject contrast into the 3 arteries. I showed it to you before, and look at the blockage. If I see a blockage, we try to put a stent or a balloon to open the blockage. Nowadays, we do that through the wrist. Again, we numb the area. We put you in sleep. So it's not a complete general anesthesia. It's kind of little la-la land. So we pass catheters all the way to the heart, inject dye, see the blockage. If it is severe, we try to put a stent. And if it is severe, means more than 70% blockage. But if you have too many blockages, where too many stents required, or you have a diabetes with the multiple blockages, we recommend bypass surgery because that's where you get best benefit. So we also assess the tubes with this technology called FFR, IVUS, and OCTs. We are in the process of getting it at GMH and GRMC, both hospitals. So the procedures, what we do, if I see a blockage, the first thing is just like a routine plumbing. We go with a balloon, make the tube bigger, but it recoils because arteries try to change its shape. Then we put a stent to give a mechanical support to prevent the recoiling. And sometimes we may need to drill it. The blockage has too much of a calcium. If my balloons and stents won't go, we need to drill before we put a balloon and the stents. So this is a patient, I think is 60 years, I guess, with a diabetes, came to Guam Regional Medical City with a severe 10 out of 10 chest pain a couple of months ago. The first thing when you come to the emergency room and the EMS people come by, this is the first test we do is electrocardiogram, ECG or EKG. We look at the pattern. It's basically measuring electricity of your heart in millivolts. So we see the pattern here. Based on the pattern, we diagnose if the patient is having any major heart attack. So this patient is having a heart attack in the bottom of the heart. So as you can see, this is a real angiogram picture on the left side. This is the CT scan picture of a three-dimensional view to understand what arteries we are looking at. So this is my catheter, and I'm engaging this left side artery here. I'm injecting contrast, which is a black one. The black one filling all these arteries. That means coming in and these arteries and here. This artery, what you're seeing here, is this artery. And this artery, what you're seeing here, is this artery. So let's play it. So when the heart is beating, the heart is moves, when I'm injecting contrast, this is the way that real-time angiogram looks like. And in comparison to CT scan, these are the tubes you're looking at on the left side. And this is another view of, this is also a widowmaker. And this is the artery, I'm looking at it. This is the angiogram. It's a procedure. This is the CT scan. So this particular patient is having a heart attack. As I said, the bottom of the heart attack, so the right side artery is involved. The left side systems, this is the right artery. This is the left artery. These arteries looking good for this particular patient. As you can see, the contrast is filling without any blockages. This is called left artery. So this is another view of the same widowmaker. This is the widowmaker. And this artery is the same thing, the widowmaker, in angio. This is a CT scan. But in this patient, the artery which is blocked is this artery. I'm going to show you next. All right. As you can see here, now this is the artery. I'm showing it to you. Yeah, this artery, I'm injecting the contrast. See, it's supposed to be like this. It's supposed to be like this, but it stopped here, 100%. Here, it stopped. So this is complete occlusion, 100% blocked artery. I showed you the pathology. It's a volcanic rupture. The cholesterol blockage ruptured and created a blood clot and shut down the flow 100%. 10 out of 10 chest pain, patient also in heart block during the procedure. If I don't open this artery in next few hours or within minutes, these patients won't make it because the significant heart muscle, the whole heart muscle is at risk. It's dying. The amount of heart muscle is at risk. As you can see, this is the whole heart muscle, the red ones, is at risk. And the next thing I immediately do is putting a wire. This is my wire, looks like. See this? This is the wire for my catheter. This is the thing, what you're seeing is my balloon. That's exactly where the blockage is, right? I put a balloon, I'm trying to open the blockage. So the balloon is in. Next thing you can see is I can get some flow and see the blood flow is going in and I'm putting a stent. See the black dot here and the black dot here? That is a stent, how it looks like in real-time angiogram. So after the stent, again, I'm trying to position the stent here to here. I'm just injecting contrast to get a right location for the stent. That's where the 100% blocked before, if you remember the picture. So this is at the end of the angiogram. The blood flow is resumed, the whole artery came back. That's a huge heart, the right coronary artery here is very big. The whole heart muscle was dying before I opened this artery. The chest pain usually resolved within minutes after I opened this tube, and the patient discharged 2 days later. and the heart function is preserved. The heart function we talked about, ejection fraction, the 55% magical number is preserved for this patient because we open this artery on time. This is a different view of a same artery here. Opening the complete, the tube is open, the stent is in. So, well, we open the blockage and we put a stent in. So what medications I do need to take? So the stent is a metal. If you expose to the blood, metal, the blood tries to create a blood clots, because if you take a blood out, put it in a small syringe, it clots. It's a mechanism of the blood. It tries to prevent bleeding, so it clots. So to prevent blood clots in the stent, you need to take a blood thinners. Those are aspirins, prasugrel, which is called like Efficient. This is ticagrelor, called Brilinta. Clopidogrel in heart attack patients is getting a second line. The first line is this, one out of this. But if you do have a normal blockage but not a major heart attack, the clopidogrel, which is a Plavix, is okay. The whole crux of the problem is bad cholesterol. So you got to be taking cholesterol pill, preferably atorvastatin and rosuvastatin, Crestor, rest of your life. I know people develop muscle pains, liver enzyme elevation, there are some side effects, but we always tell patients, you need to assess risk versus benefit. You're talking about life and death versus muscle pains. And we always have alternative medications as well. So the metoprolol and carvedilol, also good medications if patients have a heart attack to prevent future heart attacks and heart failures. These medications called lisinopril are very useful to prevent future heart attacks, are losartan or valsartan, and these medications, we already talked about it. These are like a Farxiga or a Jardiance. Other medications, empagliflozin or a dapagliflozin, or a canagliflozin. So out of this all the pathology, when it comes to normal people, and make it like a general terms, like, do I need a screening or a testing for a heart blockage? I would classify them in 3 different classes. One, person who does not have any symptoms, no symptoms. They do their day-to-day activities without any restrictions. If you know symptoms, but they have a risk factors, that means they are diabetics, high blood pressure, cholesterol, they're smokers, or a family history. So it's better to get an EKG or a calcium score, not a full-blown test. It's a calcium score of your heart arteries. It's a glorified chest X-ray machine. It tells you how much calcium is deposited in the heart. If you do have a calcium, that means you do have a heart blockage. Then we need to do something to prevent future heart attacks. So the next, the category is people who develop symptoms. That means they walk, they have a chest pains or a shortness of breath, they sit, the symptoms resolve, but not at rest. They only have symptoms at exertion. Because it is not an emergency, because they don't have a symptoms at rest, we usually do either stress test, echocardiograms, and other imagings to see how severe the blockage is, and we bring them to the cath lab on elective basis. That's when come in, schedule a date, and we do the procedures on particular date. It's just like an elective cesarean section kind of thing. So if you do have a symptoms at rest, that means sitting here and having a chest pains and shortness of breath, palpitations, then that means something emergency going on inside the heart. Then you gotta come to the emergency room to get further evaluation in timely manner. Again, time is a heart muscle. So the longer you wait in heart attack, more the heart muscle you lose. Once heart muscle died, it is irreversible. That means you're not gonna get your heart muscle back. So this is another clinic team, the spectacular, the best team. So this team make my life and Dr. Bishoy's and Dr. Polasinski's life extremely smooth, and they're very helpful. The patients love them when they come to outpatient clinic, and thanks for the dedication and the time. So I just want to give a slide to John. He's a manager, so he's going to give a little information.
So the best way to how to contact us is through our phone number as well, 671-645-5500. Our extension number is 3111. Any emails, referrals, you can send over here, refer@grmc.gu. Any questions or concerns, you can directly contact me. My extension number is 31114. My name is John again.
Thank you. So, in conclusion, heart disease is extremely prevalent and number one cause of mortality, death in Guam. And as a role of a cardiologist like me, and there are 4 or 5 cardiologists on the island, and the 2 interventional cardiologists like me and Dr. Bishoy is a plumber. We work like a plumber. Simple analogy is. So we try to do medical managements and also prevention. And when patient comes with a heart attack, we try to open those blood vessels with by putting stents on emergency basis to restore blood flow to the heart arteries and heart muscle. So and that's pretty much it we have. With that, I would like to take questions. And thanks for your attention.
All right, let's get a round of applause one more time, ladies and gentlemen, for Dr. Golla. Thank you, sir. You heard the man. He has got great presentation. Now we open up for questions. We've got our first one back here.
Yes, I'd like to ask about the symptoms of heart attack between men and women. Are there grave differences, if any at all?
I kind of lost the last thing. Symptoms of heart attack.
Between men and women.
Men and women, yes. There is. That's a great question. I just want to focus on the women. They are notoriously present with the atypical symptoms. They are not usually come with the classic textbooks and movies we see. Left side chest pain, holding it. No. They usually come with indigestion, nausea, vomiting, fatigue, or palpitations, and little dizziness. Weakness and dizziness. Of course, they do present with a chest pain and shortness of breath, but these atypical symptoms are very common for women compared to men.
Wow, that's a lot, definitely. So again, ladies and gents, as we mentioned earlier in the presentation, it's really important, Doc, to pay attention to these symptoms as they develop because time is of the essence.
Oh yes, time is a muscle.
Doc, I have a question.
Yes, ma'am.
The procedure was done Thursday. I got the coronary angiogram. When can I resume my daily exercise?
So you did have an angiogram,
Thursday.
right? Thursday.
Yes, Doc.
How did they do angiogram? To the wrist or a groin? Through the wrist.
Yes.
Usually, if you do not have a heart blockage, if your angiogram is clean, no heart blockage,
There is.
there is. So again, it case by case basis. I can only answer if you do. Let's assume if you do not have a heart blockage, we just did an angiogram through the wrist. The weight restrictions usually 5 pounds to 10 pounds for 5 days, and no driving for 3 to 5 days. Afterwards, you can do anything you want, considering no blockage. But if you do have a heart blockage, then it depends upon where the blockage, how severe the blockage, because as I showed you in a CT scan, the blockage location matters, right? If the blockage happens at the beginning of the artery, the tube,
Yeah.
the whole heart muscle is at risk. So then I don't want to let you do any extreme physical activities until it's fixed. But if your blockage is very distal, small branch, then the risk of the heart muscle is small. Then I let you do certain physical activity. It again case by case basis. Unless I know your angiogram.
70%. You said one veins only.
Yes, ma'am. But again, location matters. Anything we say severe blockage, that means indirectly I'm telling you your blockage is more than 70.
Okay, I'll wait.
But the question comes, where the blockage? Is it in the beginning or is it the end? Is it on the left side or is it on the right side of the artery? The location matters because location decides the risk of heart muscle. Ultimately, you need to know how much heart muscle is at risk. That is what I'm saving, heart muscle. Right?
Okay.
Yeah.
I'll just see you then.
But again, unless I know your angiogram, unless I see it, it's hard for me to tell you how many days of rest you need.
All right, thank you for that, Doc. Again, that's very important, guys, right? We're talking about medical situations. As much as we'd like for everything to kind of fit into bubbles, it's very personalized. So depending on your situation, as Doc mentioned, the best thing is to check with your physician or your specialist and to continue to plot forward based on your specific needs.
Yes.
My friend recently had a heart attack and she was diagnosed with microvascular disease. Her arteries were clean, no stent was needed, no history of heart disease. What are the chances of reversing the disease, and why would this happen to her? She's very active, fit. It's just really a shock, that she had it.
Yes, ma'am. That is another great question. I did not address microvascular dysfunction, otherwise called Syndrome X. So it is basically, I would say, a metabolic syndrome than a heart itself. So I want to start with a common example. What is microvascular dysfunction? The tubes, what I showed it to you in CT scans and angiogram and all the modalities, what I showed it to you today, are the epicardial blood vessels. That means the big tubes. If you see your fist, the tubes which pop up on your dorsum of the fist, those size of the tubes, I showed it to you. Those are 3 tubes on top of the heart. But these tubes, just like a root of a plant, a root of a tree, they divide and divide and divide to a small branches. For the comparison, those small branches you can see, if you look at your eye conjunctiva, the eyeball, you see small blood vessels you could see on the eyelid.
Yep.
That's how these tubes divide before it gives oxygen and nutrients to the muscle. The microvascular dysfunction is talking about the tubes almost size of the tubes what you're seeing on the conjunctiva. These are not the tubes you're talking about, the big, beefy epicardial arteries.
Okay.
So these microvascular tubes, which are also there in the heart muscle, gets injured. How? The risk factors matter here. The people who are obese, that means BMI is greater than 30, and people who smoke, people who do have a inactivity, physical inactivity, they're like a couch potatoes, and people who eat unhealthy food, like what we talked about before, and especially smoking and obesity. And diabetes, another biggest factor is diabetes. These 3 factors damage the layers of the small tubes. Once the small tubes damaged, even though your bigger tubes open, these small tubes are not letting the blood flow to the heart muscle. So imagine it's just like your biggest water tank in a city water system. Your water tank is good. Your main tubes are good. Underground water tubes are open. But when it comes to your faucet, kitchen faucet, your faucet is clogged with a crystals, like a calcified crystals, Sometimes you open kitchen faucet, the faucet is clogged, you don't get a water flow.
When you put the fat down the drain type of situation. Yeah.
Because the small holes at a faucet not getting you water when you open at the kitchen. But the whole system is wide open. The problem is at the microvascular dysfunction. The small tubes are the trouble. That is basically microvascular dysfunction. Ultimately, you're not getting water. Your heart muscle is not getting enough blood. So how to treat it? Usually metformin. If you have a diabetes, metformin helps. And weight loss does miracles when it comes to microvascular dysfunction. Weight loss is the treatment number 1, giving a metformin. If you have a diabetes, controlling diabetes. If you have a high blood pressure, hit the goal blood pressure less than 130/80. So these are the few things we recommend for a microvascular dysfunction. And statin, like atorvastatin and Crestor, rosuvastatin, also be helpful. Nowadays, we are getting, if these measures does not work, we use a medication called nitrose, which can dilate the blood vessels. which also helpful for a microvascular dysfunction. It is extremely difficult some patients to control chest pain, even though we do everything by the book. Some patients still have a chest pains. It's going to be a trouble. Then we need to do like some more modalities like the pulse therapies, external counterpulsation therapies. If the pain is still there, Dr. Dolabon is here. He sometimes put in neural stimulators to control the chest pains as well. But ultimately, weight control, blood pressure, diabetes are the crux of it.
All right, I think it's a great analogy, Doc, with the plumbing and the faucet head. We've got more questions back here.
Doc, can you explain AFib?
That's, yeah. As I said, the common 5 problems in the beginning of my slide. The third point is arrhythmia, right? I did not touch upon it today because we're only talking about heart blockages. But arrhythmias are, as I said, if anyone asks your heart rate, you tell like a 70 to 80 beats per minute. That means God has created an electric chip. Even though you don't see them, it beats around 70 to 80 beats per minute. Sometimes the chip gets dysfunctional. That means the top chambers or the bottom chambers takes this electric chip. They want to create electricity on their own. So the top chambers, when they take this electricity function and it gets irritable, instead of a regular rhythm, the rhythm gets very irregular, and it is coming from the top chambers, which are called atrias. So the rhythm called fibrillation coming from atrias, we call them atrial fibrillation. So 2 common things we need to worry about, because now it gets very irregular. Even though you're sitting and watching TV, your heart can race up to 130s, 140s, 170s, even 200s. So then you can feel these palpitations, and sometimes they pass out, sometimes they feel short of breath. Wow. That needs to be controlled. And other thing is people develop blood clots in the heart in the patients with the atrial fibrillation, because atrias are fibrillating, not contracting. It has to contract. If it is fibrillating, the blood, just like a stream, a river, right? In the middle of the river, water flows. Towards the edge, water doesn't flow. That means if the atrias fibrillating, not contracting, the blood towards the wall stagnates, doesn't flow. If the blood doesn't flow, next thing it does is creating a blood clot. So those blood clots can go to the brain, could cause strokes. So you need to be on blood thinner to prevent strokes. These are 2 common things you need to know. But there are a lot of other management. It's very common arrhythmias, but you need to see a cardiologist to discuss further. All right?
Thank you, Doc. Thank you. Do we have any more questions up here?
Doc? Yes. 1 second, sir. So the blood thinners we usually recommend is olden days, since 1950s, rat poison, Coumadin. But nowadays, it lost its glory because of side effects. Nowadays, we are using Eliquis, Apixaban, or a dabigatran, which is a Pradaxa, or a rivaroxaban. No. Heart blockages, we use aspirin, but AFib, aspirin does not have any role to prevent strokes. Yes, sir.
Okay, doctor. Yeah, my wife is, she has erratic blood pressure. She's on 2.5 milligrams of Norvasc. Primary doctor increased that, and then her blood pressure dropped real low, so she's back to 2.5. She's going up to 5, going up to 7.5 milligrams, but it drops her blood pressure low. What would you recommend that we do next?
The blood pressure management is a continuous thing, rather a binary. It is just like your appetite. One day you eat more, another day you don't eat more. So based on your hormones, how much salt you take, how much water is in body, the blood pressure fluctuates, right? Let's say one day you're working more, you need a more blood pressure. One day you're not doing anything, relaxing, you need a less blood pressure. Basically, my point is, it's a dynamic thing. It is not a single line. So unless you measure blood pressure readings, morning, afternoon, evening, at least 3 to 4 times a day, it will be very difficult to control blood pressures. Because my blood pressure, when I sit and talk right now, could be higher, 140s. Maybe when I'm sleeping, it's maybe 100. So before that, I also want to know kidney functions, your sodium and potassium and renal function, serum creatinine and other labs. It's very personalized management. But there are some medications we give first line, second line, third line. Unless you see us in the clinic, it is kind of difficult for us to tell you, oh, this is the one works for you. It is not like a one treatment works for everyone. Different patients needs different doses and different class of management. So I hear you, but I need more information.
Okay.
So, Doc, would this be a situation where maybe they could get a referral and come and visit
Yes.
you?
Yeah, I'm happy to see. Yeah, thank you.
Okay, there you go.
You're saying something, sir. The blood thinners we usually do is Eliquis. The brand name is Eliquis. Generic name is Apixaban. And another brand name is Xarelto, which comes like Rivaroxaban, Xarelto. Eliquis is Apixaban. And another one is Pradaxa, which is dabigatran. So another one is Edoxaban. There are like 4 different medications we do, but routinely we use Eliquis. Plus blood thinner, anticoagulation, yes. Aspirin only do if you're not a candidate for blood thinners, but the data is extremely limited. It is taking a risk. We usually do for young people, if their risk of stroke is less, we do aspirin, but very few patients qualify for that. Not in general, we recommend aspirin. So, you mean Angiomax? Angiomax is IV medication. It is not an oral pill to take. We do that in a cath lab. We use them in a cath lab. I need to know the real name though. It is a brand name. I want to know the generic name. All right? Yeah.
Hi, Doc. I have a question. I have a family history with an aunt that had a stroke already, like 2 years ago, and I'm wondering that is there any way we can, help with minimizing her another stroke?
Yeah, that is a little bit out of my system. Stroke is a brain thing, right? But in general, because I also did my internal medicine, we treat patients with the strokes in internal medicine training. Before cardiology, we did general medicine in general. So strokes could be in a similar way, the blockages can come, the clots can come from the heart, or clots can come from the neck, or clots even develop in the brain. So once a stroke happens, the treatment depends on why and how the patient developed a stroke, or sometimes even a bleeding can cause stroke. So unless you know the specific reason how and why the patient developed a stroke, I cannot tell you the right way of treatment. In general, let's say the stroke coming from a thrombi, blood clots formed from the neck arteries, or the big tubes shoveling the clots into the brain, aspirin, Plavix, cholesterol pill prevents future strokes. Okay? But if it is coming from the atrial fibrillation, just like I talked about, blood thinners are the key. Yeah. That stroke, then we recommend Eliquis, Pradaxa, and Xarelto. That's a whole different way of treating stroke. Both are strokes, but the source is different. Yeah, but the source, is it coming from the heart? Is it coming from the neck vessels? Where it is originating, the clot. If it is coming from the neck blood vessels, aspirin and Plavix. If it is coming from the heart, from AFib, then Eliquis.
Again, that'll be a personalized thing, right?
Correct,
To talk
yes.
with the doctor.
Hello, Doc. So this is good for just the community to know. If we're resting or if we have elderly family members in the house that may be more susceptible to a heart attack, but we're in resting mode, how would one know the symptoms of a heart attack, differences between chest pain, or when to immediately seek the ER?
Right, that's a great question. Basically, you're asking people who are sedentary, not really active, and how do we know they're having a heart attack, right?
Yes.
So the common question first we ask caretakers. Sometimes they don't even talk. People who are bedridden, they're not communicative. So the first question we ask, what is their baseline? How do they live? Like the day-to-day activities like. So what change they noticed? Most commonly they say, hey, they were looking at me, they were communicative, but suddenly they're out. Suddenly they are just rubbing on their chest. Suddenly they are breathing heavy. So these are the kind of clues we get from the caretaker. So the caretakers are very crucial if the actual person is sedentary and not active. We usually compare from the baseline how they live and what is changed. Based on the change, we suspect heart attacks or a heart failure. The first test we do in the emergency room is EKG and blood work and echocardiogram, ultrasound of the patient's heart. Based on this EKG, blood work, and echocardiogram, we will further decide the plan.
All right, thank you so much for that, Doc. So important to know. And again, very, very important to know when to seek that emergency room visit. We continue with our question line here today. Does anybody else have any questions back here?
Doctor, is exercise and medicine can still is exercise and medicine can still unclog the clogged heart?
Answer is no.
Okay.
If you do have an existing blockage, that means the irreversible process, damage to the blood vessel, cholesterol, as I showed you the schematic diagram, right? Cholesterol, it's just like a brick wall. Imagine how you make a wall. You need a brick, cement, rebar, right?
Yes.
So the same way, to create a heart blockage in the tube, you need a cholesterol particles, and you need a scar tissue, you need a calcified crystals, and inflammatory cells. That means our fighting cells. These four, cholesterol, calcified crystals, scar tissue is just like a rebar, and calcium is just like a cement. These four inflammatory cells and also the four particles, four main components, creates a heart blockage in the heart arteries. Once it comes to calcified, that means calcium crystals already created a blockage, they are not going away, just like a cement wall. It's already solidified. There is no going back. Yes, you still we recommend exercise because you are preventing
further blockage.
Progression of the same blockage. Let's say the time when we diagnose you with a heart blockage is only 20%. It won't block the flow unless it reaches 70%. Still, the blood flow meets the demand. But if you don't do healthy habits, don't do physical activity, this 20% could be a 70% in a matter of few years. But if you do exercise, control blood pressure, diabetes, cholesterol, and all these things, it may take 40 years for the 20% blockage to progress to 70%.
Oof, I like that. Okay.
So,
well, I guess that's a great question, Kuya, right? And the reason, I guess, is because we see all these things, Doc, and maybe I can put some of those Instagram, things to rest here. We see things all the time through the digital media, through the virtual media, says, drink this every morning, mix this and this and this, and clean out your arteries. So you're going to debunk all of that right now and say, once the artery plaque and all of that has been built up already, the chances and the opportunity to remove the one that's already there is not happening unless we go through the interventional methods that you proposed earlier.
Again, interventional methods, we are not taking the existing blockage out.
You're fattening
We are only pushing the blockage outside the tube into the wall. It's just like, let's say the water pipe is clogged, we are pushing things onto the wall, we are plastering, and we are putting a metal stent to recoil back to the lumen. We are not taking anything out.
Okay, so once it's there, huh? Just so we're all clear, because like I said, I fall for those Instagram things all the time, Doc. I've been eating a lot of chia seeds. It ain't gonna help me, all right? So again, I think what you mentioned earlier, if it's not the 70% and you're still functioning, that's one thing. But when you get to the level where you do need this interventional help from the cardiology team here with GRMC, that is another level, more opportunities. But as you just said, it's not getting rid of what's inside the veins or the arteries already. You're more or less rearranging to continue the flow and the service to the muscle.
Exactly. We are just making the tube bigger. That's pretty much what we are doing. We are not taking anything. One study I want to share is, of course, we are board certified. We only talk about evidence-based. If you do not have a crystals, calcified crystals, I told you 4 components, right? One is cholesterol, scar tissue, calcified crystals, and your fighting cells. If calcium is not there much, if you take a cholesterol pill like a statin, especially rosuvastatin, Crestor, There is a one study showed these blockages can regress, but they're not going to go away. Let's say it becomes 30%, it can regress to 20% and 10%. There's only one study showed so far with a recognizable study. Can I apply that to everyone? Hard for me to apply, but there is a one study showed that plaques can regress if the calcium is less in content and a lot of cholesterol is there. Yes, we can regress.
Yes, yes, Doc. Hello. Yes, Doc. This one, I want to my story of 1997. Okay, 2008 or 7, like that. Okay. I want to my story for my heart before I'm finished to my work in the night time December 24 before 25. So I going to hospital. The house first and the hospital for GMH. Say it's the time I like to sleep, but I cannot to my brain. You know, high, very high. So my heart so go up. And then I call to ambulance. They come in the house in paramedic. You know the paramedic, yeah. Then after that, I stay in GMH hospital, yeah. It's the one is only 12 hours. The start is 11 o'clock after in the morning. It's the time. So I'm lucky. I'm a strong man. Then after that, my mom stay in the Philippines, so he came back. And then they dropped me in the Philippines. So I stay over there long time, maybe 6 months. So my story of my life.
All right.
That is a
Glad you're
great
doing
story.
well.
And again, pointing from Kuya, we're glad that you're here with us today, huh? Essentially, he's saying he went to the doctor, the hospital at the time, and they told him he just needs to rest. He just needs to rest. Later, he went back because he was trying to sleep. It's too much, too much. He felt the pain in his chest, and then they called the paramedic. They did confirm he was in fact having a heart attack. So after that whole ordeal, again, it goes to show, you mentioned this earlier, Doc, this is not something we can sleep on, okay? It's better if you go to the hospital, go check, and they say, oh, you're okay, run the test, oh? Then to stay home and, like Uncle said, right? He didn't expect that because the doctor already told him he's okay. But he called again and found he was having heart attack. So it's very important, Doc, as you mentioned earlier, people pay attention to your body, right? He said baseline. We know what our normal day looks like. If something is out of the ordinary, we have to pay attention.
Yeah, agreed. And my colleague, Dr. ElBebawy, is also here. He would like to speak some words to share his opinion, how to prevent heart attacks.
Are you going to go on stage, Doc?
Hello all. Hello all. Thank you all for coming today to our session to raise the awareness and the education about heart disease. Heart disease is very common here in Guam, very genetically aggressive. We have seen heart attacks in very young age. I think the youngest I have done is 29-year-old, major heart attack. So I think genetics are very component. If I would summarize how to take care of heart problems, you have to know your problem to fix it. So the things that affects heart problem are A to F. A is age. everyone will age at some point, and heart disease is a disease of age before it's disease of genetics and everything. So I start with age. Once you hit probably the 50s, I would start being very religious about taking care of my visits with the primary doctor, making sure that my pressure is checked, my heart rate is being monitored, even the symptoms that you ignore it and you think it's not real, it's worth visiting and it's worth getting the attention, at least to make sure that it's not from the heart. So I started with the A is the age, B is the blood pressure. Make sure your blood pressure remains between 120 and 130 in the upper number. Blood pressure is a silent killer. And I can tell you that it is very, very, very common here. People can have some predisposition to having high blood pressure from genetic component, but also salty food and all these things can contribute to our high blood pressure. Blood pressure will not only destroy the kidneys, will not only destroy the heart, it destroys everything from up to toe, like stroke, heart, kidneys, legs, and this is how you see the consequence of things happen. So we talked about A, age, B is the blood pressure, C is cholesterol. You gotta take care of your cholesterol. You gotta get it checked. I'm not gonna talk about diet, but you can get the cholesterol checked as long as you watch how much you take, you watch your activity, you can achieve the balance. But C is the cholesterol, you get it checked. D is diabetes, very common diabetes here. And like I said, at some point of our age, our body is not acting like when we were younger. So the way that our body is interacting with how it gets rid of the extra cholesterol, extra blood sugar is different. So we gotta watch for these. At least once a year, make sure you get these checked. E is exercise. Very important to keep an eye on your activity. 10,000 steps a day will be very good. You have your phone, you check your steps and everything. And then F is the family history. Dig through your family history. Ask who had heart disease. Every patient I do at a young age, I tell them, make sure your kids know that you had heart attack at this young age, because they themselves would be at very high probability of having so, okay? These are just A to F that I wanted to mention today. We are interventional cardiologists. We tend to put stents. We like the intervention, but I would rather do the prevention before I do the intervention. So as late as we get into us, that will be good. I don't want to see young age on the table. I rather see you when you are at the right age, not at young age. Even if you don't want to see me at all, that would be perfect thing for your life. So just take care of your A to F and enjoy your day.
Thank you, Doc. Thank you. A great line of thought again. A great line of thought again. Preparation. One more time. Let's get a round of applause for our amazing team here. Thank you so much, Doc. All right, I think we're open to a few more questions. If there are any out there, we'll take them. If not, any question?
Yes, Doc. What's the difference between a stroke and a heart attack?
Stroke, usually we deal with a brain, and heart attack with the similar kind of presentation to the heart arteries. So far I showed it to you, the plumbing system, the tubes supplying the blood. Suddenly the blood flow shut down due to rupture of the cholesterol blockages. So basically blockage in heart arteries causes heart attacks. The blockage in brain arteries causes stroke. One more exception is not just a blockage, sometimes blood vessels rupture in the brain, cause hemorrhage, also can cause strokes.
I'm sorry, but my brother passed on, I don't know whether it was a stroke or a heart attack, but 16 days later, he passed. But he went into 4 days recovery, then 8 days in, what do you call that? No, where he can't.
Coma?
Coma.
Okay.
And then 8 days he passed. So I just would like to know, was it because his eyes rolled back, his tongue stuck out, He slammed his head back on the asphalt on the road in Santa Barbara walkway. So I never got any information. I don't know why. So I just would like to know if you have any kind of feedback or anything.
I think it's a definitely difficult question to answer without more information. So obviously you have a right to ask for a medical records, obtain medical records and review them. Every physician who are in medical care, they're supposed to document what kind of treatment they provided. Once you know the conditions what they treated, you will have a better answer. Because if your heart stops for briefly, causing brain damage, the brain stops, eventually heart stops, everything in organ, they work in a symphony. If one organ stops, other organ eventually stops. It's hard to tell which one started first. So unless you look at the actual medical records. All right?
All right. Well, thank you so much, ladies and gentlemen. Let's get a round of applause one more time for Dr. Golla. Thank you, sir.
Thank you. Thank you, everyone.
All right. Thank you again. Thank you, sir. And now it's time to move through. Again, if you have any questions about any of this, our team is still standing by ready to answer those questions for you. You can set up some situations with your doctors and eventually get that referral to meet with Dr. Golla and the crew here at GRMC. Right now, I'm going to turn this over, ladies and gentlemen, please, from our executive team, Mr. Eric Plinsky.
Hi, everyone. I want to thank everyone for coming out. I'm Eric Plinsky, Chief Business Development Officer at Guam Regional Medical City. This is a great event. Dr. Golla, Dr. ElBebawy, I want to really thank you. All of our team who really spent all of yesterday, really all week getting ready for this, coming out on a Saturday to help make sure everybody gets the information they need. We're going to try to continue doing these on a quarterly basis. Last time was neurosciences, about the brain and stroke and spine, and now this is heart. We've got many other specialties to talk about. Cancer, which is the oncology department, urology, orthopedics, wound care, and for diabetics that have usually lower extremity wounds that won't heal, pulmonology for the lungs. What else do we got? I think we've got many more. It's general surgery. So, we got a lot to share with you. I want to make sure that before we go and do any drawings or stuff, that there's a list there at the cardiology table. If you think you or a loved one might benefit from a meeting with one of our doctors, all you got to do is put your name on that list, and our team will call you or your doctor, your primary care, and they'll work to find out if there's a way we can help you do a test, help figure out if there might be something you need to be aware of. So I would encourage you to just put your name on the list. We can check. Doesn't mean you have to come, but it allows us to get in touch with you outside of this event. The other thing is, Kyle mentioned, we have another list for 25 people. I don't know if that list got filled up. It's full already. All right, so the free EKG. But even though you may not have made it on the free EKG, anyone who's got health insurance, they're going to pay that anyway. You can also sign up, and we have EKGs and all the testing at the hospital. So put your name down so that we can find a way to get in touch with you and then find out from you, your doctor, or your health plan if you might be eligible and need some extra testing at GRMC. I'm going to turn it back to Kyle. Kyle, thank you very much for coming. He's our go-to guy whenever we do any event at GRMC. Kyle is our MC, and you can support him. Is it Power 98 now? Is that where you're at? Okay, thank you very much.